Good evening. Can everyone please take their seats? We're going to get started. Welcome to Survivorship 360, a town hall style meeting exploring survivorship care plans from every angle. Tonight we're going to learn how you can use these survivorship care plans to take charge of your health care after active treatment for breast cancer ends. I'm Catherine Ormerod. I'm the Vice President of Programs and Partnerships for Living Beyond Breast Cancer, and I'm thrilled to be here with you. Living Beyond Breast Cancer is a 23-year-old organization that provides trusted information and a community of support to people impacted by breast cancer. I would particularly like to welcome our two audiences we have today. As you may have heard, we have this wonderful in-person audience here at the University of Kansas Cancer Center, and we have over 700 people who are joining us via web stream from across the United States. So welcome to you all as well. While we encourage people, we will take a lot of questions from you, and we will do so for the people in our in-person audience through texting, if you're comfortable with texting. If you're not comfortable with texting, in your packet, you have index cards, and you can write your questions, and they'll be collected and posed to our folks joining us via web stream. You'll see the text number at the appropriate time. We'll talk to our distinguished panel first, and then we will open it up and answer your questions. I'd like to thank our sponsors tonight, the University of Kansas Cancer Center, as well as Back in the Swing USA. We also have another, I think, Kansas City legend. Silpada is our sponsor, and we're grateful for Silpada's support as well. To set this framework for tonight's discussion, I want to tell the story of Luann. Luann is a volunteer at Living Beyond Breast Cancer. She's a 23-year survivor. And she told me that there were really two pivotal moments in her breast cancer experience where she felt vulnerable, confused, overwhelmed, and afraid. And the first was when she was diagnosed, and the second was when her medical oncologist said, "Congratulations, treatment's over. I won't need to see you for many months." She felt kind of abandoned. She is actually a reporter, so she had lots of questions. You know, what does the chemotherapy mean to my health going forward? When do I need to see doctors? What doctors do I need to see? I'm not really sleeping now. I'm obsessing over recurrence. What should I do? So the medical community has been thinking about this as well. And about a decade ago, the Institute of Medicine responded with a report called Lost in Transition about sort of giving name to this idea and this fear, and also making a recommendation that survivor care plans could really help people. So survivor care plans should be unique to the individual. They should talk about what your treatment was, what your stage of diagnosis was, what your treatments were, and they should also provide you ideas on what to expect in terms of scans and other care. Also, they can deal with the psychosocial issues that you might anticipate, but they are unique to you. So it's been 10 years, as I said, and these plans have not been widely adopted. However, we have an opportunity now. The Commissions on Cancer, as of January 2015, are requiring hospitals and cancer centers that receive accreditation through them to provide these survivor cancership plans to people. So this is a great opportunity, and this is why we're here tonight, to help inform you so you can ask for what you need. So I mentioned we're going to have that opportunity to text questions, but I also want to remind people in the audience to mute your cell phones, keep them on so you can text your questions, but please mute them. We are also having people tweet tonight, and the hashtag is hashtag LBBC360. So that's Living Beyond Breast Cancer 360. Okay, So tonight, as you may have seen in your program, Dr. Carol Fabian, who is an internationally renowned researcher here at the University of Kansas, was supposed to be with us tonight. At the last minute, she could not. So her colleague, Dr. Jennifer Klemp, will bring some greetings from her.
Thanks,
Dr. Klemp?
Great. Thank you very much.
All right. Thank all of you for being here tonight, both in person, obviously, and those that are on the web. Dr. Carol Fabian is a nationally known expert in breast oncology, prevention, and survivorship. She is not able to be with us and does wish us all well this evening. But I think the moral of her story is really, where did breast cancer survivorship really evolve from, and where are we going? So I wanted to start by really talking about what seems pretty basic, but what is a cancer survivor? And I think that anyone who builds cancer survivorship programs really needs to start with this definition. When Back in the Swing helped us in 2004 start doing focus groups with survivors to say, hey, you know, what do we want to call our clinic? How do we want to address you? We use this definition from the time of diagnosis through the lifespan, and that also includes caregivers. But when you start thinking about that, a lot of people don't resonate with that term. Maybe a patient's still getting cancer treatment. Maybe that word just feels like it should be used in a different context. But at the end of the day, the term survivor has been branded, it's out there, and it tends to at least pull us all together into a group. But I think this is a very important definition to start with. Now, with the change of different types of treatment, and many of you in the room or on the web have had what we call targeted therapies. Maybe when you had your breast cancer, they did a biopsy, and they looked at certain features of the cancer and gave you very specific treatments based on what those, the tumor biomarkers told us. That's called personalized medicine. We're able to treat you with not a one-size-fits-all, but with something that's specific to your tumor type. And that's really, I think, the important message about survivorship. It's not one-size-fits-all. We are a growing population, as you can see. Back in the 70s, so about 40 years ago, you know, we had less than 3 million cancer survivors with early detection, more targeted therapies, and with patients doing much better from their treatment. By the year 2022, we will have almost 20 million cancer survivors. So what's that telling us? Number one, it's telling us there's too much cancer. But we also have a critical mass that we have to deal with. And I think that there's expectations that need to be set up. Number one, we know that you want to keep with your oncologist for the rest of your life. But is that possible with a shortage in the workforce and a growing number of survivors? So how do we better prepare our medical community, our survivors, our caregivers, and all the community resources that we depend on to care for patients as they go through their cancer journey? I think the moral of the story, though, is just like your treatment's personalized, so is your survivorship care, and that's what we'll discuss tonight. Thank you very much.
Discussion. I'll start again. To start the panel discussion, I'm going to turn to Barbara Unell, CEO and founder of Back in the Swing, and the co-author of the award-winning Back in the Swing cookbook. So Barbara, for the past 15 years, you've been a wonderful advocate for cutting-edge treatments for breast cancer survivors. What fuels your passion?
All right, I'm going to take a cue from Jen and
Go
come
ahead.
up to the podium. Thank you very much. And thanks to all of you and all of you on the web for caring and for listening and for wanting to advocate for your own good health. That is, in fact, as you said, what drives this passion that I have for good health, for getting back in the swing. We take that name literally. Our name is our mission. And what drives me to do this is a question that I asked about 16 years ago. Just simply, now what? After my breast cancer treatment ended, I asked that very simple question about where's my plan, not even knowing the word Survivor Care Plan, not knowing that 16 years later, I would be standing here at this moment in time, which I believe is a new conversation, a great conversation, the conversation actually to have about where we're going. And as Dr. Klemp said, the 20 million cancer survivors, each one of these individuals, I am very confident, is asking that same question I asked that many years ago. And why I asked that question was because I wanted to feel in control of my recovery. I wanted to know what I could do, not in 3 months when I came back for more scans, but what I could do that afternoon to help make sure that I built my bones up and took care of my fatigue and took care of my heart and took care of all of the things in my body that was affected by my treatment. It seemed like the reasonable thing to do. Well, it was the reasonable thing to do. It not only was the reasonable thing to do, but it was, as we have seen now over the past 15 years, where this business of cancer care is really going. It's not enough just to provide the treatments for the cancer cells, the cancer tumor, but also all of our bodies, our entire mind, body, and spirit that is affected by the treatment for the cancer. That's what I wanted then, and that's why I'm so thrilled to be here today and so thrilled that all of you are here to have this conversation. Back in the Swing was started in 2000 to help on a grassroots level to make a difference in the medical field, to build what I call the test kitchen, which is here at the University of Kansas Cancer Center. It opened in 2007, long before the Commission on Cancer's report that as was talked about, is mandating for accreditation these kinds of programs starting in 2015 and beyond. But it did respond to the need that we saw at a grassroots level, that people weren't getting the kind of care they needed. They weren't getting, as they say, the total care. And what I want to say, just in beginning this night, is a great big thank you to all the physicians, to all the champions, to the folks on our panel, to the nurses, to the social workers, exactly, who made this change possible. It was the advocates who supported Back in the Swing and have supported Back in the Swing for this many years, the advocates who supported Living Beyond Breast Cancer for so many years. It's all of us together that have caused this night to happen. And I couldn't be more excited to be here and to be sharing this podium with my great friends. Thank you.
Thank you so much, Barbara. Dr. Klemp,
Yes.
I understand you have a few slides
Yes.
for us, and I want to also introduce our third panelist on the end there. That's Lori Rinaldo. She is a breast oncologist, nurse practitioner here at the University of Kansas. Welcome,
Great.
Lori.
Thank you so much, Kathy. Well, tonight we wanted to give you sort of a bigger glimpse of what survivorship should look like. And at the University of Kansas Cancer Center, as Barb mentioned, we did open our program in 2007, really not knowing how to deliver care. We knew what our patients were telling us, we knew the late effects our patients were experiencing, and as I mentioned earlier, with all the targeted therapies, what was going to be next? We don't really have a lot of long-term data on some of the combinations of treatment, and now that many of you will be on endocrine therapy even longer, what is that going to look like for you 10, 15, 20 years down the road? So this is a pretty simple infographic that we built to basically explain how we wanted to describe survivorship care and how we wanted to build our program. So as you can see, the first place that we all start, and frankly, it's what ends up happening after a diagnosis, we want to focus on prevention, screening, and that could be of late effects, it could be of another cancer, and it's really important that we have the education that we need so that we're taking those steps for adequate prevention. But once a diagnosis has occurred, most people feel that survivorship is going to start post any type of treatment, and according to some of the publications out there, it's really only for those who are free of their disease. But the reality is, if we go back to that definition, it's every patient from the time of diagnosis. So starting at the time of treatment, many things that you experience are actually part of survivorship care. Maybe you were visited with a dietitian or a cancer rehab specialist, or my practice, which is cancer genetics, maybe we met and discussed what your personal and family history looks like. So all of these pieces really go under the umbrella of how to make sure that your survivorship experience starts from day one, and we're addressing the needs that our patients have early on. Now, we don't always do such a great job of this. Many of you have experienced what we call chemo education, where we kind of dump a whole lot of information on you at a time when you're nervous and anxious to start treatment. And then we don't always do a good job providing different time points of education. And just like Kathy mentioned with her friend, there are transition points which lead us to a need for additional education, and hopefully documentation like a care plan provides what we call knowledge transfer. What do you need to know today? What do your other providers need to know? And I think that this journey really is very fitting of what happens for our patients. Some patients never will leave the treatment phase of their journey, and those are patients who still have very significant survivorship needs. We just recently published an article talking about the unmet needs of women with metastatic breast cancer, and they go everything from financial and wanting to maintain their job to body image and sexual health. These are things we can address, but we don't always ask the question. So we need to provide that education to our patients so they can provide us with the issues that they need addressed. If we get patients into this phase, that could be patients on long-term endocrine therapy, or for many of our patients, triple negative, or those who don't require endocrine therapy, then they're not going to have additional treatment. So what do we do with them? A lot of people kind of like taking that pill every day. They don't like the way they feel, but they like taking the pill because it reminds them that they're getting some treatment. So I think it's very important that we give alternatives to patients at this time. That includes lifestyle, diet and exercise, and we want to work with our community partners, whether it's web-based resources, whether it's a cookbook, to really empower our patients to have the tools they need at home, because they don't need to come back to the cancer center to do an exercise class. We need to make sure that they have safe opportunities close to home. And then what we call continuity is what Lori will describe in a really nice case study. It's where we also manage patients long term. It's where they go to get screened, and it's where we can manage them and really evaluate their symptoms. And I'm going to throw out a term that you may not have heard before, but as Lori describes her practice, we try to have what's called, if you will, an oncology patient-centered medical home, where she's really the quarterback to make sure that the needs are met of the patient and that we're getting patients screening and other services that they require. This slide is a little bit kind of like a flower, but it shows that multidisciplinary approach to cancer survivorship. So we start, obviously, with those acute individuals in our lives, oncologists, surgeons, radiation oncologists. But what about that primary care? Did you see your primary care on a regular basis? No. Do we insist that you see the primary care? No, because sometimes it's kind of easier for us just to manage that. But the more isolated primary care is from that experience, unfortunately, they're not in the loop. They don't know how to co-manage. So we've also built some additional education, which you may have seen on the first slide, at Cancer Survivorship Training, to start helping those shared care partners, like primary care or other specialists, learn how to care for a patient in a shared environment. Now, if we sent a patient to every single one of these specialists, you would be like, I am not going to one more doctor. So what's the key? Well, just like in genetics, we need to stratify your risk. If we see a patient who walks in the door who already has risk for cardiovascular disease, who already has diabetes, we know that that patient is at higher risk. So we need to use our clinical judgment, we need to use risk tools to better assess your risk so we can match you up with services that you need outside of primary care and outside of an oncology practice. I think some of the big issues that we do need help with is managing sexual health, fertility. Those are a natural fit. One of the things that we have just presented, and Lori and I presented at the ASCO breast conference just in September of this year, was, you know, if we told you to go get a colonoscopy, how many of you went right out and called that scheduler and got your colonoscopy? Probably not that many of you. And actually, statistically across the country, if an oncologist and a primary care tell you to get your colonoscopy, 25% of the time you get it done in the prescribed time frame. But when we started taking on that responsibility as part of our survivorship clinic, we have a 77% show rate now for the colonoscopy. Not because it's the most fun thing to do, but we know that our cancer survivors are at risk for other cancers. We know that other cancers are preventable. So I think it's very important that we really map out what you need, what your risks are, and personalize that to you. The Survivorship Care Plan is a recipe, just like in the cookbook. But if you don't have all the ingredients you need, then your recipe is just a piece of paper. And so that's really kind of the take-home, is that survivorship care is this umbrella that pulls all those ingredients together that you need in your basket And we have to make sure that you have access to what it needs to be a good and fruitful recipe. So with that, I will transition over to Lori, and she can go through a case study with you. Go.
I'm just going to sit.
You're going to
here.
sit. You're perfect.
Good evening.
Oop.
I'm Lori Rinaldo. I'm a nurse practitioner. I've been in practice in women's health and specifically breast oncology for 21 years. I've worked with a great breast surgeon here, Carol Connor, for many years, and then had the privilege of working with Dr. Fabian for the last 12 years. When breast cancer survivorship started at KU, it was exciting. And it continues to be exciting because we're doing good things for patients and we're doing the right thing for patients. So I'll just describe a little bit about what we do. The elements of a care plan, certainly it's a living document. It's not just a piece of paper. It's not going to mean anything to a patient if you print out something and hand it to them. It needs to be specifically for their situation. It's not appropriate to counsel patients for cardiotoxicity or cardiac failure as a result of your chemotherapy if you didn't get cardiotoxic drugs. So it's very specific. And it should be a summary of their treatment, including surgical treatment, radiation treatment, and any kind of chemotherapy, endocrine therapies. Whatever that patient has experienced should be summarized. Actual and possible late effects of treatment are very critical because patients don't know. They heard that when they signed the consent, when they agreed to take chemotherapy, but it's not in the forefront of their memory, and it's certainly not something they want to think about every day, but it's our job to watch for those late effects of treatment. Cardiac risk, bone loss from their endocrine therapy, and multiple other things that we're going to talk a little bit about. What to report, signs and symptoms. If you tell a patient you took a drug that could affect your heart long term, but you don't tell them what signs and symptoms to watch for, then I don't feel you've done a very good job. But if you tell them that if they have extra swelling in their legs, if they have sudden weight gain, if they have heart palpitations or feel extremely short of breath or profound fatigue, and they've had a drug that could affect their heart, that could be early signs of congestive heart failure. And that's something that I need to know as their provider, because then I would get them to the appropriate caregiver. Risk stratification, and again, I've kind of touched on that, but certainly being familiar with what treatments you had and your provider knowing what treatments you had is critical. Again, a cardio-oncology referral system, we're very privileged here at KU, and because of the generosity of Back in the Swing and our physician champion, Dr. Fabian, all the other Coleman Foundation, all the Living Beyond Breast Cancer, all of these organizations have been so critical in the development of what we can do for patients, and it's such a privilege. But cardio-oncology is a specific type of clinic that was set up here that if I identify a patient, and again, risk stratification, that has had cardiotoxic medication, may have a family history of sudden heart attacks, has diabetes, high blood pressure, is overweight, there's certain criteria that that patient meets, and they should be referred to cardio-oncology. There they're seeing a provider that specializes in cardiac disease and can watch for any symptom signs and can do the appropriate testing. Distress screening is critical. I think it's very important, and it's a difficult thing to do. And many places have tried to institute that as part of their intake form. We're certainly working on that diligently, but identifying where the patient's stress is very important. Is it finances? Is it their spiritual needs that haven't been met? Is it body image or relationship changes? Cancer and treatment can change relationships. It can change the way people feel about each other. And if someone's dealing with that, I want to be aware of that so I can get them the help they need. A psychologist or any of the other, a social worker that can help them with those finances. Our drugs are expensive, and sometimes that's a barrier to them getting the treatment they need. Symptom management, hot flash management, sleep deprivation, chronic fatigue. The list just goes on. And there are resources out there. There are facilities that can help. There are exercise programs specifically for breast cancer patients. And as providers, we need to know what those are. And we're the link between that patient and what they need to get better and to get back to their new normal. Lymphedema is something that we deal with every day. Axillary dissections, even sentinel lymph node biopsies can cause a secondary problem of swelling in the arms. So that's important to be aware of that and know what resources you have for that. And then family history and genetics. Certainly, at time of diagnosis, that is addressed, as it should be. But that should be addressed as you progress forward, because your family history can change. And that can change what we recommend for you. Maybe it wasn't appropriate for genetic testing when you were first diagnosed because you were the only person infected in your family. But maybe now you have a sister and maybe, an aunt. And so addressing that at repetitive visits is important. And then coordinated share of care. I am an advocate for getting the patient where they need to go. I can't do everything, and I'm not going to, monitor lipids and everything else. There are people that should do that. So I have great resources and referral bases. I've worked really hard to do that and to establish those relationships. And then, what's the next step? Patients need to know, what should I anticipate? Should I come back in a year? How can I get a hold of you? And what should I be watching for? So we'll just talk about a case study. Mary's a 56-year-old, I can't see sideways, postmenopausal female who was diagnosed with a left breast cancer about 6 years ago. Her breast cancer was triple negative. So if you know what that means, it's estrogen negative, progesterone negative, and HER2 negative. So we don't have specific targeted agents to treat that. I'm sorry, she was HER2 positive. So she's not triple negative. I don't know who did that. Okay. So she was treated with lumpectomy, which is a removal part of the breast, with an axillary lymph node dissection followed by radiation therapy. She also received adjuvant chemotherapy with adriamycin Cytoxan followed by Taxol plus Herceptin. She got Herceptin because she's HER2 positive. And that was for a full year of treatment. Finally, she received 5 years of an aromatase inhibitor, which is because she's ER positive. Okay, so if you think about that patient and their clinical picture, what should we be looking at? Well, certainly cardiovascular disease, because she had an anthracycline and a HER2 targeted agent, which is Herceptin, which can also cause some cardiovascular issues. Menopausal symptoms. Again, she's not going to get estrogen again, and we're going to block estrogen with her endocrine therapy. So she's going to have hot flashes. She's going to have vaginal dryness. She may have some mood swings. Weight gain, certainly. Breast cancer patients, one of the only breast cancer diagnoses that I know that patients gain weight. Fatigue can be a chronic problem. Joint pain because of their treatments. Peripheral neuropathy because of that Taxol they got. They're concerned about recurrence every day, and I get it, and that's why we're here. Lymphedema, certainly osteoporosis because of endocrine therapies and lack of estrogen. Cognitive function, chemo brain is real. Don't let anybody tell you it's not. There's been many, many studies, so there are things we can do to help with that. Secondary cancers, and then psychosocial issues, fear, grief of loss, grief of, I'm not the person I used to be, feelings of relationship changes, body image, financial problems. All of those things are kind of a synopsis of the potential complications or issues that this specific patient may encounter. Assessment of symptoms, late effects, and changes in family history. What can be done to improve quality and quantity of life? And what is that shared survivorship care plan? What should it look like? So what are the next steps for Mary? Certainly, unfortunately, this patient is divorced since her diagnosis of breast cancer. And she's struggling both financially because now she's a single person, and her self-image has changed. So we can have referrals to social work. We can send her to a psychologist. Mary's gained weight and lost muscle tone. We have oncology rehabilitation specialists in Kansas City now that are available to help with our patients. We can encourage lifestyle changes, weight loss programs, exercise programs, programs at Turning Point, jazzercise, all sorts of things. Review of family history. Her family, there's a positive cardiovascular history. So, and there's new cancer in her family. So we can refer her to a cardiologist for risk stratification and treatment. And we can also send her back to genetic counseling to get tested, because now she has a new family member affected. And in this case study, she was a BRCA carrier. Her daughter was tested BRCA carrier. And so they need to make some decisions about what they want to do. So being cancer-free is not the same as being free of cancer, and that is true. So I think that's powerful.
Powerful statement. So, Lori, as your one slide showed, that it's a very detailed one-page piece of paper that's a survivorship care plan.
Mm-hmm.
But Barbara, you deal in how to take that piece of paper and really turn it into a plan for living. So can you explain how to do that?
Sure. Thank you. Yes. Well, all of you heard about the situations that can affect a person after treatment. As I said in my opening comments, the now what question is about preventing some of those consequences of treatment. It's also looking at the science that now tells us a lot more of what we can do. As Dr. Klemp said, even early on, I asked the question at the end of my treatment, but now there's so much prevention that can happen, even at the point of diagnosis, in terms of preventing these side effects that Lori talked about, as well as preventing recurrence. Information is a lot that we've heard tonight. Information can be fearful, a lot of what we've heard tonight. But as you know, the name of our organization is Back in the Swing. And so what we've done, thanks to Andrews McMeel Publishing, is create a book called the Back in the Swing Cookbook, Recipes for Eating and Living Well Every Day After Breast Cancer. The reason we wrote the book, and the great joy of the 300 pages in the book, is that it takes some of this data, the science-driven information, that you might not be able to receive at your patient visits. There just may not be time to spend to look at the studies, to understand the implications. And the great question that I've always asked since I've been a little girl is why? Now we hear about why that we should exercise. We hear that we should have maybe modulate our soy, but why? And sometimes the why is an answer that we don't get from our doctors, but we can get it now through the joyful, I like to say, Healthy Back in the Swing Cookbook. And there's 5 areas of that cookbook, and that's another reason that we love this book around the country. It's being used in cancer centers and by folks who aren't even diagnosed with cancer to understand how to prevent some of this disease issues that we've talked about today. One of the things of the Back in the Swing lifestyle has to do with this very thing we're talking about tonight, which is good information from your physicians. This new kind of care, this new day that's dawning, that will be rolled out over the next decade, really, across the country, deals with the survivor-specific medical care. But what about those 364, if you will, other days of the year? When you wake up and you wonder, what can I do back to control today, tonight, this afternoon? There are 4 other areas. One's nutrition. Another is positive emotions. There's lots of data in this book that actually, I have to say, the expert that we called her Professor Positive. She is a professor of positive emotions and mind-body medicine, and that's sprinkled all throughout these 300 pages. The other piece that's so important is movement. The information about movement usually addresses issues around heart. We're now a lot more conversant with the fact of moving so to improve our heart function, et cetera. But there's so much data around heart and prevention of recurrence of cancer and also to help the chemotherapy become more effective. That's in that book. That information may not ever trickle down or be, as they say, translated into the news you can use, so to speak. And then the other area is around relaxation and mindfulness. Again, you never heard about meditation, right? You never heard about yoga and cancer before, but now it seems like there's a yoga studio on every corner. Well, there's a reason behind that in terms of yoga, relaxation, mindfulness, and the effect on our immune systems, the effect on our bones, the effect on all the things that Lori talked about and Dr. Klemp talked about. There's real science behind that, and that's what drives me and Back in the Swing to translate that science and make sure that you can use it every single day to, as we like to say, get back in the swing.
Thank you, Barbara. So we're very privileged to be here at the University of Kansas with such a great healthcare providers and a great philosophy and lots of resources. But many people out in the audience do not have the same resources. People in rural areas or in underserved urban areas. So Jennifer, what do you suggest for them?
Well, we are lucky in the state of Kansas to have a great network called our Midwest Cancer Alliance, where we as the academic center feel a responsibility to all of our partners across the state, and hopefully a shout out to Salina, Kansas, who's watching right now. But one of the things that means is that we have to figure out how to translate the care that we deliver when there's only 2 oncologists, 1 nurse, maybe a nurse practitioner, and there's no mental health professionals. So what does it look like in different environments? And I think that the key to delivering survivorship care is that if it's not one size fits all for the patient, nor the organization. So if you're in an isolated rural community, if you're in a community practice, you need to have affiliations with hospitals. You need to know all of the resources that are available as part of these organizations here tonight, as well as many others. We've actually started developing iBooks as well to help educate patients along their journey so that they can be an extension of what Lori's telling a patient. Or early on, when you're sitting there and you're idle time, because unfortunately sometimes you have to wait for your providers, wouldn't it be great to have a little iBook? And I can show you guys what those look like. So I think it's really being creative. It's being able to meet the needs of the patient, and if we have to use technology, if we have to make sure that we have resources through phone-based interventions, which we do a lot of in the state of Kansas. We actually have patients call on a conference call line. And you may say, well, heck, why wouldn't they use a webcam? Well, not everybody has high-speed internet. So I think we have to be very practical, and we have to have solutions regardless of the size of the organization, and we don't need to reinvent wheels. We need to collaborate with all these wonderful organizations that have resources for our patients.
And that's a role that, as Barbara mentioned, that patient advocacy groups such as Living Beyond Breast Cancer can play. We have information on our internet 24/7. We have programs about fears of recurrence, about intimacy and sexuality, and about financial issues, because those are becoming increasingly important as cancer care becomes increasingly expensive. So as a patient is going along in this journey, Lori, I'm wondering what advice you would give to the caregiver of the patient. What can he or she do to really help some of this come along?
I think probably one of the most powerful things that a caregiver can do is just to be available, to listen, to be a sounding board, to attend as many appointments as you can. I know that's not always possible, but to take notes. And that caregiver can be, anyone. I mean, it doesn't have to be their spouse or their daughter, or it can be a friend. I think that my dad went through cancer, and just hearing what the physician and the nurses had to say was powerful. And a lot of times he didn't hear it. He was overwhelmed with all the information, and being there was such a blessing because I was able to be an advocate for him. And I think that's really the role for the caregiver, is just to be the advocate. You need somebody on your court. You need somebody that's watching out for you. And if you don't have anybody, there are organizations that provide help too, that can attend your appointments with you. There's ambassadors that are willing to do that.
Okay. That is our presentation portion of the program. And so for our in-person audience, if you want to write down your questions, we'll have people collecting them. Or you can text the number. We're going to put it up on the screen. We have already gotten a few from our web friends. So in a moment, you'll see it. Remember, you can also be tweeting, if you like, hashtag LBBC360. So there's the phone number. While we're waiting for the phone number, I'm just wondering, just a real practical question. So I have my survivorship care plan, or I don't have it, and I go online, and I go to lbbc.org or Back in the Swing, and I see where I can find at least a template that I can start to organize. When I am experiencing fear, when I am first completing treatment, what are some of the things I can expect in the coming year? So what are some specific scans and treatments that people are most commonly concerned with?
Do you want me to answer that?
Sure.
Yeah. Certainly an open conversation with your provider about what type of surgery is recommended, what type of chemotherapy is recommended. That's basically your care plan when you start. It's your recipe of what targeted therapies or what treatments that physician thinks appropriate. I would highly encourage you to ask questions. And frankly, if your physician doesn't have time to answer them, find a different physician. Because you should be a partner with that doctor and, or that nurse. Find someone in that practice group that will answer your questions and take the time to tell you what you need to know about your treatment.
No, I think that's a really good point. I think one of the pieces that's different potentially around these issues of survivorship is the language. Oftentimes you may not know the official name of the chemotherapy, let's say, or official name of the radiation, or even the kind of tactics that are happening in terms of biopsies. But you can talk about these other 4 areas that we talked about. You can be conversant. You know, in a regular lifestyle, if you will, about nutrition, about exercise, about these things. And so feel in control, back to the word that we've been using a lot tonight. Feel that you can ask these questions without any kind of qualifications. That it's your body, it's your future, it's your health. And also you understand that that's a part of, shall we say, living beyond breast cancer. It's a part of, shall we say, getting back in the swing. It's a part of your life. And so you are taking the chance, you're taking the risk, you're putting down the gauntlet, and you're saying, I'm going to get this treatment, this primary treatment.
It's part of surviving.
And it's part of surviving to get this treatment that we've been talking about tonight. So do not think it is secondary, or you think it is ancillary, or perhaps not necessary. The data is there to show the impact of the work that is being done here and done across the country.
And if that physician has their hand on the door to leave and you're not done asking your questions, tell them to come right on back.
So one thing, just building on what Lori and Barb have said also, is in relation to Kathy's question about scans, there are good information. In particular, the American Society of Clinical Oncology has something called CancerNet, which is for patients. And so it can outline what those standard screenings or next steps would be for you. They have great resources. But you have to remember, you may have had bilateral mastectomies. So a mammogram might not be appropriate for you. So make sure that if you have that information, that you're seeking out, those recommendations, because once again, it's not one size fits all.
That's right.
I would like to return to women and men who have breast cancer with stage 4. The word survivor is a big turnoff sometimes. You address that in your opening comments, Jennifer. But you also mentioned that people living with metastatic disease who will be in treatment for the rest of their lives, they too can benefit.
They can.
And can you explain a little bit how?
Absolutely. I think the research that we just published was both urban and rural breast cancer survivors. And there were so many similarities between the two groups. The only thing really different, the urban women were a little more skeptical and asked a lot more questions of their oncologist versus the rural women who were much more trusting of the oncologist. But the issues went into themes, and I think that's the important thing to think about, is what was the very first and most common theme that patients reported? They wanted to feel they could contribute in their life, whatever that was, whether it as a mother, if it was doing dishes at home, if it was going to work. And some patients have to work to maintain their insurance. So that was the number one most common theme, was life role, is what we called that. The second was body image, sexual health. They didn't feel attractive to themselves, they felt their partner didn't want to look at them or touch them, and their partners were scared. I've actually had a patient's husband ask that if my wife is getting chemotherapy, is it safe for me to be intimate with her? I mean, that's a very valid question that if you don't have the education as a partner, that may scare you. And in particular, what about radiation therapy, chemotherapy? So I think that those are issues where when a patient comes in to see their doctor, they're focused on, has the cancer progressed? What do we need to treat them with? What do their blood counts look like? And we're not always thinking about the bigger picture, which may be your priority. So I think that we're trying to have tools like symptom management screeners or distress screeners to identify those issues, but we still need our patients to tell us what those most important issues are for them. So when I start a consult, the first question I say is, why are you here today? What do you want to accomplish in this visit? And I find that to be very helpful in really strategizing what we want to make sure we accomplish.
Thank you. I have a quick related question here from our internet audience, and then we'll get to some questions with Kevin. A woman is wondering, she has had breast cancer before the age of 45 and has 3 daughters. So should she get the BRCA test, which is the gene test?
Well, one thing I would say is please go and watch the webinar we did on Living Beyond Breast Cancer's website, which does talk about a lot of the changes that are happening in genetic testing. As many of you know, if you've been tested for BRCA1 and 2, those are the most common genes associated with hereditary breast cancer. However, there are other genes associated with breast cancer as well, and we're starting to use more expanded panels to identify patients and their families at risk. So for that patient, we've actually just developed a new one-page tool, and there's also lots of electronic tools to fill out a family history. So a 45-year-old with no family history, it really depends. What's her family structure look like? Does she have a lot of players on the field, is what I call it? Did her mom have only a brother? Was dad an only child? So if you don't have a lot of players on the field, you're not able to accurately assess risk. And unfortunately, family structures have gotten a lot smaller over the past 2 decades. Also, what kind of cancer was it? If she was a triple-negative breast cancer, we're absolutely going to test her regardless of family history if she's 60 or younger. So pathology of the tumor makes a difference. So I think that the answer could be possibly yes, but we'd want to look at some of those other factors too.
Okay. Kevin, we have a question from our in-person audience.
Yes, we do. It's a great question from one of our folks here who's attending the meeting. I'm a 2-year survivor and finished my treatment in October 2013. Is it too late to get a survivorship plan?
Great question.
Never too late.
It's never too late. It is absolutely never too late. You can print off one of the forms from the internet, take that into your doctor's appointment, and get some information. You can ask for a copy of your record, or you can schedule an appointment with the physician's nurse if they have a mid-level provider in their practice. That's a good resource. And schedule some time so that you can sit down with your provider and really talk about what you should be looking for.
And I think there's 2 things also I want to build on what Lori said. The first is, I think we really need to switch when we start building a survivorship care plan. So like Lori mentioned, you have a treatment plan that you get up front. That should really be the beginning of that documentation. We need to set expectations with our patients. We need to provide you with that information up front. So you deserve a treatment plan, and then along the way we would update that. So that at the end of treatment, you'd get a summary of your treatment, plus start discussing the next steps of survivorship. And I think the other part of that is that many of the things that we do are survivorship care for our patients. So we need to make sure that if we give them a note, if you see one of Lori's notes, it has all this information in it, but it may not look like that pretty, gridded piece of paper. So we have to do better at explaining that information to you too, because you probably are getting a good dose of survivorship care, but it may not be framed that way, and we need to make sure that we're working together.
Great. We have lots of questions about soy and eating. And I'm wondering, Barbara, if you want to talk about the role of diet, perhaps a little bit about the role of soy and what's safe for breast cancer survivors or not.
Yes. In fact, we have a page in the Back in the Swing cookbook that was actually vetted by, and this particular piece, a nutritionist actually from the University of Kansas Cancer Center helped us devise this page, particularly lots of pages, but one called To Soy or Not to Soy. That is the question. I mean, an entire page on this. And the reason there's an entire page is exactly what we've been talking about today, is it's personalized, and it's very important. I say this all the time, it's a complicated answer. People don't like to hear that. They want to say, well, just tell me whether I can have it or I can't have it. But all these factors we've been talking about, what was the makeup of the tumor? Was it estrogen positive or negative? What is the daily diet? What is the weight? What is the issue in terms of menopause? So many different factors around this ingredient called soy. And sometimes people might not even know that they're getting soy when they have this great,
Soy lecithin.
bar. I won't name any names, but a energy bar, if you will. You may not know the names that, if you look at the ingredients, that might be actually, 26 grams of soy, but you don't even know you're getting that all in soy. So I hate to say it, but it's a complicated answer. And I would talk to a nutritionist at wherever your health provider is, whether it's your primary care physician or a specialized nutritionist or at your cancer center. But that's a great question. But again, framed around a positive frame, it's what can I have, not what can't I have. How can I enjoy soy and not worry about it? As you can see, releasing the fear out of all of these areas we've been talking about will also help in that term survivorship and enjoying life.
Oh, yeah, I was just going to say that what we usually recommend to patients is dietary soy. So if you're going to have a little edamame with maybe some, teriyaki vegetables, that's a good way to get your soy. But if you're doing protein shakes and you're using a soy protein, we recommend not using those more therapeutic doses of soy or isoflavone.
And soy milk, and a tofu burger, and you're
All
in
that,
trouble.
yes.
Right.
So it's really dietary, 2 to 3 servings a week. But you don't always know what's in lots of your
That's right.
ingredients.
That's right.
But as Barbara mentioned, talk to your doctor.
That's
Exactly.
correct.
Talk to your doctor.
Exactly.
Kevin, another question from the audience.
Thank you. Yes, another great question. Lori, you touched on this a little bit, and I think it's actually would be like the follow-up to what you had said. The question is, I just finished 5 years of Arimidex treatment. My oncologist does not want to see me again. Is that normal? What should I be looking for future
It's a loaded
care?
question.
That's the question.
So, certainly after completion of treatment, most medical oncologists will discharge their patients back to their primary care physician. And that is where partnering with those primary doctors is so important. There are late effects of taking endocrine therapies, loss of bone health, and those types of situations. So either getting in touch with a survivorship provider, talking to an advanced practice nurse, talking to your oncologist again, get some guidelines from them about, what does this mean now for me, and then partnering with your primary care doctor.
Lori, if I could, please. When I was researching this topic, one of the things that I found very interesting was the disparity in the number of oncologists who said that they were actually filling out one of these forms, but then the actual receipt that a primary caregiver had actually gotten it. And there was a huge gap in that number. Can you maybe address that and maybe what people can do to ensure that that correspondence is moving back and forth the way it should?
Right. I think with the improvement in electronic medical records, I think that we're going to get a lot more partnership between providers because it's going to be easier to get that information to them. And I think a personal responsibility of the patient as well. So if you're completing treatment and you're being discharged from your oncologist, I would want a completion summary. I would want a copy of my last medical office visit note. And I would want to go over that with them and say, so what do I do now? And is this information going to go to my physician? And then when you see your physician, did you get that record from my oncologist? And if not, I have a copy. So I think, taking some power yourself too, and being involved in that partnership is very important. I think you'll see better outcomes.
I think also There's this interesting respect that physicians have that they don't want to step on each other's toes. So also when you look at some of the notes that we send to primary care and we see the patient back and they haven't received the recommendations that were in the note, and you talk to that primary care physician, they'll say, well, I didn't want to, overstep my boundaries or step on your toes. So I think one of the great things that Lori's been able to do is really delineate, hey, we're going to take care of these things. Primary care, this is your job, and specialists, this is your job. Because if it's not delineated out, then really there is this lack of kind of ownership because people don't want to step on each other's toes.
And I think that's the whole, really, not the whole, but one of the underlying principles of this movement, of exactly what we're talking about today, is that people are realizing there has to be this shared information. Even the primary care or other specialists are needing to know what is the risk for this patient. They may not be trained, a cardiologist or a rheumatologist or any of those people may not be trained in their area in terms of onco, and then put the name of the specialist after that. So part of this evolving mission that we're launching today is to say, we're on the sort of cutting edge of this, but we as consumers or patients can bring those documents to these specialists and then help this conversation be more circular, don't you think? and integrated?
Absolutely. And having that relationship between those physicians. I've had OBGYNs call me on the phone and say, hey, Lori, I'm seeing one of your patients and, can I give her some vaginal cream because she's got terrible atrophy from lack of estrogen? And we talk about it and we can work together on that. Well, a limited amount or this kind or that kind, and we work as a team. And I think that's really important.
And also being aware. If you are hearing from your doctor in terms of estrogen, and it's really important not to increase your estrogen because of the tumor, and then you go to your gynecologist and you're being given something to boost your estrogen, it's part of your responsibility and opportunity, as I like to call it, to say, hey, wait a minute, and ask that question, and realize that that's your opportunity to take care of yourself. And look at it as self-care, which is, again, this patient-centered care that we've been talking about. Very, very important, because that gynecologist may not want to do harm, but may not even understand the implications of that drug.
There are a couple questions that are coming in about how to access these templates. So again, there are people who do not have access, perhaps, to a great cancer center such as yours. So go to Living Beyond Breast Cancer. It's lbbc.org or Back in the Swing to access the resources. And as Jen said, the template that we saw, which we are providing a link to, is on asco.org.
That's
right?
correct.
asco.org/survivorship. Yep. There's a lot of questions about exercise, not surprisingly, but also about a woman who says she exercises quite a bit, but she still likes to have a glass or two of wine. Is that okay? Of course.
There's everything in moderation. I think the key is what we like to use the term energy balance. We use that quite a bit in the book, and I think that it really fits what life is all about. We've run multiple diet and exercise studies in breast cancer survivors. Some of you probably participated in the audience here. And I remember a woman saying, I got on the treadmill and I worked off exactly 140 calories according to the heart rate monitor, but then I could have my wine, which was 140 calories. And I'm like, well, they're not actually even Steven calories, of course. But I think the key really is that we need to exercise, we need to be moving most days of the week, and we need to get our heart rate up, because that's the only way our heart gets stronger, is to actually get that heart rate up. I think that we know that alcohol can increase the risk. We've seen that in multiple studies for breast cancer, but those are also in those individuals who are probably having more than just a glass of wine with dinner here and there. So I think the moderation piece is important, and you should discuss that with your physician if that's an important part of your quality of life.
There's also a study in the book. I like the headline of the story. It says, alcohol, not so much. And the reason, because it showed the demonstration in terms of the research showing in terms of risk. We've talked a lot about risk. Right. Reducing your risk, that's one way to reduce risk. Right. Again, all of these things together hopefully make up a positive lifestyle. Again, what can you have, not what you cannot have.
Well, and I think that is the quandary of risk, is that we are all we live in an environment, so there's our genes in our environment. I had a great grandpa who smoked a pack of cigarettes a day and worked in a coal mine and lived to be 94. why was that happening, right? So I think the key is we need to have balance as to what works with our life. We need to reduce as many risks as possible, but you need to have the quality of life that's very important. So I think that those are all factors that have to go into how we assess risk in general. And for most of our long-term breast cancer survivors, they're not going to die of breast cancer. They're going to die of cardiovascular disease. So if we silo you and we don't address those issues, then we're missing the boat for that survivor. So I think those are all important pieces to kind of know your risk.
We have another question. This is perhaps a conversation starter with a healthcare provider. She's had treatment for lymphedema and she still has slight swelling. So she's anticipating it going away. Is it going to go away, Lori?
Well, unfortunately, lymphedema can be a very chronic condition. And you can have exacerbations of lymphedema. You can have episodes of it getting better, it getting worse, infections, cellulitis. So a good management of those problems and working closely with physical therapy or occupational therapy because it may require long-term care.
And that's something a survivorship care plan
Absolutely.
could really help with.
Absolutely.
And
Kevin.
Lori, if a patient has lymphedema, are they at higher risk of another flare? I mean, does that kind of prime them for another episode?
It does. Yes, it does.
Kevin, another question.
Thank you, Kathy. From the audience, an often asked question actually about a particular side effect of treatment. Please advise, chemobrain, how to treat and or manage effects.
There you go. Well,
Well,
I
you're
luckily
from the
did my
psychosocial-
dissertation on cognitive performance, and it was in premenopausal women who ended up having treatment, and we just did 10-year follow-up on these patients. And the first thing that I've learned is that we can give you a battery of tests and assess your cognition. And we're all going to, at some point, not do so well on those tests. A 3-hour battery, you're going to have some challenges. But there are reasons we do that because we're looking for certain areas of the brain. One thing we call executive function, like how do we perform in a work environment, recalling words. So there are certain domains that definitely are impacted more. Now, how do you kind of find the chicken or the egg? Is it because you're fatigued? Is it because you're not sleeping? Is it because of the treatment? Is it because of the cancer? Is it because you just are going through menopause? So there's a constellation of issues that impact cognitive performance. And so one of the recommendations that we give is you kind of do a stepwise process. The first thing, are you depressed? Is there an untreated depression that we need to deal with? The second is, are you sleeping okay? Third, are you exercising? So we really go through kind of some steps to make sure that we can kind of weed out what's left over and then look at different tools. We know that things like, crossword puzzles, lumosity, all of these types of things that challenge your cognition really are working those muscles, if you will. So important to deal with those issues. We found in this study that women by the end of their second cycle, if they were premenopausal, were biologically postmenopausal. So you're going through a rapid menopause. So of course that's going to have a change to your body. So I think that the answer to that about how you treat it is you kind of do a stepwise process. We have to do some behavior modification, and then we have to figure out what tools will be helpful to help that patient.
Someone texted in that she didn't notice that reconstruction was mentioned in the Survivorship Care Plan. What is
What I didn't hear.
reconstructive?
Reconstruction.
Yeah. she's-
So it's very important to not only know if it's implants that your reconstruction is, what kind of implants, are they saline, are they silicone, who your plastic surgeon was, if you had a autologous flap or like a latissimus flap or a deep flap or a tram, and what to watch for in those because patients develop scar and what we call fat necrosis, and that can feel like a lump, and that is terrifying, So reconstruction is a very important part of breast treatment for some patients, and for other patients it's not so important. But if it is important, then making sure that that's part of your care plan and understanding what type of treatment you had, what kind of surgery, and what to watch for long term, whether you need mammograms or not. And those are all questions to refer back to your plastic surgeon.
Now, what if we have a patient who's 10 years out, she didn't have reconstruction, but she asks that question. Is she able to have reconstruction down the road if she's already had surgery and it's 10 years since her diagnosis?
In some cases, yes. If there was enough skin left over from a mastectomy, if there's not a lot of scarring on the chest wall from radiation. But certainly if that's something that's important to the patient, I refer to plastics all the time.
I think we
In
have patients who
long-term
think,
survivors.
though, that if they miss that window, that it's not an opportunity.
Yeah, it is.
And it can be at any point, it's just that
Absolutely.
discussion.
Absolutely. In fact, I just had a patient that has some asymmetry, had a lumpectomy with radiation, a lot of contracture of the skin, and one breast is much, much smaller, and she's 12 years out, and now she's decided that maybe she wants them to be more similar. So we just referred her to the plastic surgeon.
Great. Okay, Kevin, question.
Thank you again, and my apologies to the author of this question. I am going to paraphrase a bit. Can the panel address how survivorship care plans can be of great benefit, especially when looking at the genetic risk, genetic testing? The question that was posed was from a woman who was diagnosed in her 50s, her daughter in her 30s. She's asking, what about her daughter's daughters? And how can this survivor plan really benefit all of them?
Sure. I think it's interesting because a lot of times you'll see multiple generations of cancer and women will ask, well, my mom had a different kind of cancer than I have. And so pathology isn't always the main indicator that there is a link. However, it can be. So there are certain types of pathology that are more common with some genetic predisposition. But I think that having a documentation of what happened to you is important. So for instance, I had a patient today, a new 37-year-old, and she went in for fertility treatments. The fertility specialist was smart and said, hey, let's get you worked up and make sure there's nothing going on. Unfortunately, there was something going on. So she brought in a care plan actually from her aunt. And it was helpful because it talked about her family history. The patient didn't even know she had that family history. So these are tools that can be shared, and especially if those family members are no longer with us, or there's obviously estranged families as well, that piece of paper can be very helpful. It also guides us as to what type of mutation is, if there is one. Also tells us what kind of testing. And as I mentioned, there's all kinds of newer update tests where we can do more types of genes. So if we tested a family member for a smaller single syndrome, like just the BRCA1 and 2, maybe now we would test, which we've done how many times, we'll test the daughter or a family member for the larger panel. So very important to have that as part of that ongoing documentation.
That's great. We're getting a lot of questions about recurrence and fears of recurrence, and people want to know, and they want to test, and they want answers. And I know that there is no test, and there are no specific answers. But how can, maybe Barbara, how can the Survivorship Care Plan give you a little bit sense of control and how you can look for things that might be signs of recurrence or health?
Right, I think there's sort of two parts to, and I think I might, my co-panelists might address this as well. Two parts to that question. One is fear, I mean, just in general, the notion of once, what I like to say that particularly with breast cancer, you're minding your own business, you're living your life. It's not like you broke your leg or you just tripped on something or you were in a car accident. It sort of tests your ability to trust your body because just you were hanging around and all of a sudden this thing happened, you had no idea. You're also not typically, a person is not typically sick in the sense that we typically say in terms of someone has pain somewhere. Sometimes, of course, it does manifest as pain, but many times not pain. So I think this notion of fear comes from a lot of complicated, and maybe perhaps you all want to chime in on the fear part a little bit, because I think it's important.
And talk about how you address that to educate the patient.
Right. So fear is real, and especially right after the acute phase of treatment, because we're not doing anything actively usually. And so patients are encouraged to call us, and my nurse Mary's sitting here and she knows because my patients do call us. But I give guidelines of if you have a symptom that is concerning for a recurrence, and I go through what those symptoms are, shortness of breath that's unusual, palpitations of the heart, nausea that won't stop, bloating in your belly that just you can't explain, a headache that lasts for days and days and days, a specific pain in a bone that you cannot explain, it won't go away, and it just progressively gets worse, and it's been there for 3 weeks despite Tylenol, et cetera, et cetera, et cetera, they know to call me. And I want them to know that if they bring in a concern to me, I will address it. I'm not going to ignore your symptoms. So I think having that powerful conversation with your provider is important too. Like, hey, this is not normal for me. And most women know instinctively that something is wrong. And so that cannot be ignored.
Right. But I think in sort of tandem to that.
And so knowing you can get a
know,
hold of somebody and
right.
get that workup it relieves the fear.
Exactly, and I think too, the second part of that question also is that there are so many pieces of information now of things one can do to help prevent recurrence based on the science that shows it improves your immune system, improves your bone health, improves your heart function, improves your thyroid function. That data was not around years ago, so that all we had was sort of waiting for, what do you say, the other shoe to drop. And I think that's the first part of my point was there's this sort of generalized fear, but then your brain takes over in terms of not looking at the emotions of it, but looking at the science of it and saying, oh, wait a minute, there are things I can do. Right. And then, of course, a provider who can help reassure you. But it is also normal for every single sort of first thought is, uh-oh, that's what that is. And I think you need to start look at that and maybe, again, look at how generalized your fear is. But there are things you can do, and that's back to the care plan and the follow-up care. But it's important to differentiate what's sort of your overall fear and then taking information and using it to build confidence.
Right. And building on that too, a lot of you are saying, well, where's the test? Where's that test I can have? And some of you have had some of these tests. So if any of you have endocrine positive tumors, maybe you had an oncotype or a similar type of a test that gives you a score. And maybe they gave you chemotherapy to hopefully reduce your chance of a recurrence. We also have newer tests out that tell us should we leave patients on their endocrine therapy longer because they are at higher risk. We also have tests that tell us about circulating tumor cells, which are being researched, that could we use that as a blood test to predict who's at higher likelihood or to have progression of disease. And then many of you probably have what we call tumor markers. Have any of you ever had CA 2729s or 15-3s for your breast cancer? The American Society of Clinical Oncology says we shouldn't be doing those in asymptomatic patients. But I was just speaking at a conference this weekend, and there was a great dialogue about, well, those tests were used in old school treatments where we only had, 2 or 3 options for combinations of therapy. But now there's different types of targeted therapies, and we're using therapy differently. So I think that tumor markers, although not recommended unless the patient's symptomatic, I think there may be kind of a resurgence of, okay, well, let's up the ante and find new markers that could be useful for prediction. So those are all kind of out there and on the cutting edge.
I think an important point to make is that when breast cancer does recur, we should not blame the person because we don't know why it recurs.
We don't.
So you can do everything right and still have your breast cancer recur.
Yeah.
And that's the area of research that we really hope will figure that out.
And I think from the provider perspective, some providers do like to do these blood tests of tumor markers or scans because it reduces patients' anxiety a lot. Maybe the patient's worried. Now, if you look at the data, it gives you a 4 to 5 month lead time on that recurrence. So from an outcome perspective, it doesn't change the outcome, but there's a psychological perspective to that as well. And so I don't think, as Kathy just said, you can kind of discount what the patient's experiencing, definitely not their fault, but how do we put all that into perspective and make sure we're doing the right things for the patient?
Okay, Kevin, another question.
Yes, and sorry about that. I also, too, wanted to mention very quickly, Kathy, if I may, that in each of the packets that you received, you'll notice from Living Beyond Breast Cancer, you have a publications order form. We've touched on a number of the very things that we have in those publications, fear of recurrence, lymphedema. All of those publications are offered free. You can download them online. You can call our toll-free number, or you can send in the order form. That's actually the back page of that pamphlet, and we'll be happy to send you the guides or the guides that you need. So it's a great resource, and we're really, really proud of those. This is a really intriguing question. I had cancer 3 times, not all breast. What do I do now? And I think that it really offers us an opportunity to discuss comorbidities and how they relate to the overall survivorship care plan and what we should be thinking about when we're talking about comorbidities.
So Lori, would you like to please first define comorbidities?
Wow.
Yes, what are comorbidities?
Right. So as part of the survivorship care plan and as part of taking care of the whole patient, I have a very holistic view of taking care of patients. And that's why I'm very persistent about colonoscopies and about patients seeing their GYN oncologists or GYN doctors and their endocrine doctors and all the different care providers that work with us. I have had patients in my practice that we've picked up secondary cancers, totally unrelated to their breast cancer or the treatment of. And taking care of that whole patient is very important. But still, in that situation, that person has survived. They are surviving, and there are going to be issues. If it's, lung cancer or colon cancer or their breast cancer or leukemia or whatever they have to face during their journey, there's resources available to them.
Right.
And it's important to have all that information together so that your providers can take the best care of you.
And one of the reasons that we push knowing that change in family history is that if a patient has a genetic mutation, they have a 65% chance of a second primary. And if we don't know what their risk is, because we didn't assess that and do any genetic testing, then they're at a whole lot of risk, and we're not prepared for managing that risk. So that's why sharing that information, knowing your family tree, is really important to your health care.
Okay. We have several people, actually, who have talked about being on tamoxifen and being totally miserable. I hear chuckles in the audience. Any suggestions, Lori?
Right. So I think that's a fair comment because certainly some patients, I should say most patients, that are on tamoxifen have some side effects. And I think you have to weigh the benefit and the risk. What is that benefit? Does taking that tamoxifen reduce your risk of recurrence by 50%? Yes. So is that worth it? Yes. Are there things we can do to manage those side effects? Yes. Are there things we can do to help with menopause symptoms from tamoxifen? Yes. And knowing what those risk factors are, knowing what side effects to anticipate, and then having an open conversation about what to do about it. Because certainly adherence to medication is probably one of the biggest problems we have in oncology today.
Yep.
Because a lot of our treatments are oral, and we trust the patient to take it at home. But if you are having miserable side effects from that drug that we say is going to help you, are you going to take it? And so having an open conversation, I've had patients that have told me, I do not take it. And, so that's a conversation that we have to have. And they have to understand what that risk is. But having the choice is important too. Quality of life is very important. And so I think number one, if you are having miserable side effects from your treatment, talk to your physician or your provider about it. If there's no resolution, then you have to make some decision based on benefit and risk.
And I think what was presented at the American Society of Clinical Oncology meeting in June, which talked about should you stay on your endocrine therapy 5 years or should you take 10 years, is really caused a lot of stir. Because does every patient benefit from that 10 years? No. And so that's why coming up with some of these new tests may help tell us that. But if you had a patient that wasn't adherent to their therapy at year 3, they're sure not going to be adherent at year 8. So I think we have to be very realistic about what's practical and really try to symptom manage those patients because all the data that we give patients is based on patients staying on drug. And as we know, unless we ask, do you take your pill exactly how we described every single day, you're not going to get the answer. If they filled their prescription, then that's a fill and that patient's compliant with their therapy.
Right.
That's not being compliant with the therapy.
And one of, I think, the other pieces that, again, back to what you talked to your physician, I think that's been a recurring theme in this conversation. There could be things that the person can do to help make that those side effects less toxic and less shall we say, of a problem in terms of the quality of life. But if the doctor doesn't know that these things are happening,
Right.
And they can't help.
and then they can't help.
Right.
So it's critically important that the consumer, as I call him or her, has a new frame, I guess part of this new conversation around this, that it's a frame around control, it's a frame around quality of life, it's a frame around these people are part of your team, this patient-centered approach, and they want you, A, to take your medicine, they want you to be healthy, thereby this new movement in survivorship care. It's really a new conversation, and I think consumers need to be much more proactive in terms of that, as opposed to saying, I'm just not going to take it, I don't like the side effects.
Right.
There are things they can do.
And the aromatase inhibitors also cause people a lot of side effects. We completed a study several years ago showing maybe management of vitamin D levels could be helpful. Last year at the San Antonio Breast Cancer Symposium, it showed that exercise helps. Initially, exercise and arthralgia, which is the joint pain, doesn't feel so great, but if you can get over that hump, the exercise actually can improve that. So there are things that we need to be encouraging patients to do, and even though it may hurt a little bit up front, it's just like anything that ends up being good at the end. We have to kind of push through that.
Okay. We're getting to the end of our program here. Who should be providing the survivorship care plan, and who should be managing the person's care?
Right.
So frequent questions.
So I think we should start with explaining who does our accreditation standard tell us we should, what we should do. So the Commission on Cancer has put out a mandate that needs to be phased in over the next 5 years, starting in 2015, that any accredited hospital have that delivery of a care plan to a patient that was diagnosed in their hospital. The American Society of Clinical Oncology has kind of helped make that a more tangible mandate, because mandates for us are hard, and we have a lot of mandates from a lot of different ways. We have fewer providers, more demands, and less resources. So we have to depend on our partners out in the community to help as well. So when we look at who should deliver that, it should be physician-directed care. But the physician has a team. There's a nurse practitioner or a PA. There are nurses, there's nurse navigators. And so I think that you have to really look at the team in caring for that patient. The mandate says that it should be physician-directed, preferably delivered by a physician or a nurse practitioner, because those are providers for our patients. But I think we also have to be realistic that a lot of places don't have access to ample resources, but it does need to be delivered in a fashion where it's given to you and there's communication about what that means. Most of our patients would prefer just the communication because we want to spend more time with them and they want to spend more time with us. So we don't want to be distracted once again by a piece of paper. We want to deliver good quality health care.
Okay. I'm going to ask each of the panelists to address two final questions. We're in a transition time with these survivorship care plans. That's pretty clear. So what is your best hope for them? And what is some practical information that you can provide to people to take home tonight and to start implementing tomorrow? Can I start with you, Lori?
Yeah, I'll start. My hope is that a survivorship care plan is a living document. It's a conversation between the provider and the patient, and that it's something tangible that they can take with them and feel empowered. It's knowledge, and it's going to help them survive. And that's what I want to see. And that's why we're all moving forward with this mission, because it's valuable. And practical advice. Open conversation with your providers. Tell them what you're feeling and let them know what you're experiencing during that journey. Because if you tell them, they have more ability to help you. But if you don't share that with the provider, they have no way of knowing what's really going on. So that's my practical advice.
Okay, Barbara.
You shouldn't give me how much time you have, right? I think the first piece of the question is what my hope is on a personal level for this work that we're talking about. I started out by saying that it's a team approach, that because of people like those sitting on my left and right, we are where we are right now. It takes a commitment to health. As you can tell, we've been talking a lot about everything but really about cancer. This is a health issue. This is the biggest health issue, I believe, facing us, seeing the numbers of folks who are diagnosed with cancer. This is not really about cancer at all, in my opinion. This is really about advocating for the best life possible. And if, in fact, a cancer diagnosis comes along the way, what we've been talking about is this response to that diagnosis, and then how to heal from the treatments that unfortunately cause side effects near and late. But thinking of it as a health issue, like other health issues in our country and in our lives, I think helps to, again, decrease that fear that we've been talking about. You want to walk, you want to run, you want to see, you want to hear. Everybody wants those health benefits, right, of being human and having a brain that can actually dream and hope and actualize what they want out of their lives. This is no different. And that's, on the practical side, what I believe these fantastic pieces of information we've been having. I wish every single person in the world could have heard this conversation tonight, because I think it puts it in a perspective that is around health, that is not around fear. And still, there is so much fear around cancer. But if we can advocate for our own bodies, mind, and spirit on every day in other ways, then we can do it if a cancer diagnosis comes along. So on a practical level, I think this is just the beginning of this new conversation, and I am encouraged, very encouraged that we're having it.
All right, so what do I hope for this care plan movement? I hope that we can have shared care. I hope we can have primary care and specialists and a whole entire team that really does feel empowered to care for our patients. We all have some sort of training. We all will have cancer patients in our practices, so I think it's our responsibility to be able to care for cancer patients wherever they are in their journey. And meet them where they are in their journey. The practical piece is you can only solve fear with knowledge and education. There is so much information out there, so we have to use reliable sources like we have here, because I think it's really important that you don't get misinformation or information that will lead you down a path. I often tell our patients they're banned from most websites except the handful that we give them, because that can get very scary and very distracting. So knowledge is important, but the right kind of knowledge, and be your own advocate so that you can have some control back, because cancer kind of takes away that control, and you're trying to find some way of getting that, and lifestyle, movement, all these types of things can be very helpful in you gaining yourself back.
Great. Please join me in thanking our amazing panel for tonight's program. A couple of, before we get the music going, a couple announcements. We are having a raffle both here in person, that once we close down the web streaming portion, we will do the raffle. Barbara will pick the lucky winner. For those of you in the web streaming audience, you will receive an evaluation tomorrow, a link to fill out that evaluation, and once you do that, you will be eligible for the raffle. And what the prize is a Back in the Swing cookbook, so be ready for that. Just a few more notes. Please go to lbbc.org to find some resources. We also have some